right, it looks like we met the quorum. Let's give everybody another 30 seconds. Okay, right now it's 7:50. Let's start our meeting. Welcome everyone to our June DUR meeting. Just a few reminders for our meeting today. If you are dialing in via telephone, Google Meet has muted you. If you would need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute their device via Google Meet. DUR board member, please reserve your question until the end of the presentation or ask in the Google Meet chat. For public comment, if you would like to provide public comment, a conflict of interest form must be on file. So please send an email to medicaidpharmacy@utah.gov. Attendees that are not members of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. Thank you, and I will leave the rest to Dr. Cannon.
All right, welcome everybody. Another happy Thursday morning. So let's get things rolling. Everybody should have received a copy of the agenda, a few pre-reads, and minutes from the previous meeting. Hopefully everybody reviewed the minutes from the last meeting. And are there any comments, questions, or changes that we may need to the minutes? All right, hearing lovely silence. Do we have a motion to approve the minutes?
May I propose that we accept the draft minutes?
Thanks, Kumar. A second?
Second.
Thank you, Dr. Weinstein. All in favor?
Aye.
Aye.
Any opposed? All right, the minutes are approved unanimously. Next on our agenda, and I'm assuming we have no housekeeping items or anything today.
We do.
Oh, we do. Okay.
Yes, Jen will be giving a housekeeping item today.
All right.
Hi, everyone. Good morning. Just a couple updates we wanted to share with regard to some housekeeping items and some policy changes that are going into effect on July 1st. The first I may have mentioned, well, both I've probably mentioned in prior meetings. One is the launch of our diabetes prevention program coverage for eligible Medicaid members. This policy will allow members who are considered, first of all, 18 years of age or older, have a BMI of 25 or higher, and they are not yet diagnosed with type 1 or type 2 diabetes, to be eligible for enrollment in one of these programs. These programs have to be certified by the CDC as part of their evidence-based diabetes prevention program. But Medicaid members are eligible to be enrolled and receive educational and instructional counseling around lifestyle changes. And of course, many of you know that this program has been very successful and demonstrated success over decades of time, actually, in helping avoid diabetes in at-risk individuals. There are 2 codes that will be used to bill for these services. And one is 0403T, which is a daily rate code, which allows for face-to-face counseling. And then the other is a monthly rate, which is 0488T, which is a monthly rate code that can be used. So we're excited to launch that program. The other program we wanted to talk about is our medication therapy management program. This program is eligible for both adults and children. We left our requirements pretty open simply because we don't have MTM software. So typically when we have an MTM program, we're able to run claims data through the program and identify individuals who qualify. That is the way that sort of Medicare runs their MTM program. So you're able to establish sort of a set number of medications, a cost for these medicines, as well as a set number of health conditions. And you can even define what these health conditions would be. We received limited funding for the launch of this program, and it would not be able to support software. So as a result, we really wanted to encourage enrollment in the program and participation for pharmacists to be able to conduct these MTM consults with members. So the criteria then is that, first of all, the member has to be Medicaid enrolled. It can be adults or children. We know we have many children with complex medication regimens. So the consult, of course, would be given to the guardian or the parent in this situation. We are requiring that it is a face-to-face consult because of our coding and our funding that we've been given. So it is face-to-face. The individual cannot be eligible for Part D, otherwise they'd be receiving MTM through their Part D benefit. We do have a requirement of at least 3 medicines to prevent 1 chronic condition. So again, like I said, we don't have a software that can kind of refine who this exact population is. So as a result, we left it pretty liberal. We do have some documentation requirements, which are outlined in the policy and will be posted on our pharmacy webpage, our resource page, so that people can reference what they are. We are using the comprehensive medication management tools from Pharmacy Quality Alliance as a guidance for this service. And let's see, we can bill 3 different codes and actually be reimbursed for them. So the CPT codes we're looking at are 99605, 99606, and 99607. These are all face-to-face MTM assessments that are reimbursable by pharmacists who provide these. It will require documentation and delivery of these services. So we are requiring that there is a formatted letter that goes to the member and also goes to the primary care provider to establish coordination of care and be able to have complete, take-home materials for the member as well. Any questions on these 2 policies?
I have a question, Jen.
Yeah.
Are children eligible for the diabetes prevention program?
They are not. The bill specified that it would be for individuals 18 and older, and so we met the requirements of that.
That's a shame.
Yeah. Yep. Understand there are many children who are, yeah. Any other questions? Okay, and then a couple other updates as well. I did want to just touch on the consolidation of our Department of Health and Human Services, just to make you aware of these changes that are occurring. And I know we've talked about them before, but the Department of Health and Human Services will be officially merged July 1st of 2021. This does change the role of the Medicaid program so that it is within the Division of Integrated Healthcare. And I believe I've shown a graph before, an illustration of what this looks like, but our organizational unit will exist within the Healthcare Administration section. The Healthcare Administration section is made of the Division of Integrated Healthcare, as well as the Division of Long-Term Services and Support. So my role is to oversee the Division of Integrated Healthcare, which includes the Medicaid program, the CHIP program, the State Mental Health Hospital, as well as the Office of Substance Use and Mental Health. And with this, it will bring our behavioral and physical health services and the operations of these under one umbrella of the Division of Integrated Healthcare. So many of you know Brent Kelsey, who is currently the Division Director for Substance Use and Mental Health. He will serve as a Deputy Director within the Division of Integrated Healthcare. And we already are working very closely and collaboratively in beginning this work as an integrated division. So we do believe it will result in improved whole patient care, and want to embrace the opportunity we have to really impact delivery systems, the administration of our behavioral and physical health services, and certainly directly this will influence the Medicaid program as well. And we're really excited about that. The last thing I wanted to note is that many of you are aware of Governor Cox's One Utah Health Collaborative. initiatives around enhancing the delivery of health and promotion of health across our state. There are, in fact, I know Dr. Hoffman's on, and she serves on the executive board for the One Utah Health Collaborative. Dr. Hoffman, I don't want to put you on the spot if you're not in a place where you can share for a moment, but I did want to touch on the importance of this work. And for all of you who are in different settings across the state, we would love for you to engage in this work in the capacity that you are able to do. Dr. Hoffman, if I see you come off mute and hear you want to speak, that'd be great. Maybe just going over the 3 goals and collective initiatives, and then I'll touch on some Medicaid specific roles.
Yeah, and I can throw some links into the chat for people to try to, you can use those to engage in the collaborative. They're accepting any ideas that you have. But the idea is that we're trying to pilot value-based healthcare initiatives to address 3 primary goals: affordability, equity, and outcomes. Not that different from other models that we've seen related to the triple aim and other things in population health management. But the idea is that the collaborative will become a 501c3 separate from state government, but leverage funding sources that the state has control over, including our Medicaid dollars. So we're expecting some focus in Medicaid, and Jen, maybe you want to speak specifically to some of the primary high-level goals that Medicaid has set in anticipation of a public launch of the initiative at the end of June from the governor's office. And so we're excited and talking about lots of different innovative ideas. We've basically been through a stakeholder engagement phase where we've been doing forums to large groups of people as well as smaller ad hoc forums. Probably have spoken to hundreds of different individuals across different areas, from community-based organizations to businesses to payers to the healthcare systems themselves. And it's really, we've really hit some saturation of themes, I'll be honest. I think we've got a nice set of marching orders in terms of the directions we'll go next, but we're anticipating the 501c3 to be formed, hopefully at the beginning of the summer.
Thank you, Dr. Hoffman. And then, I would like to sort of announce what Medicaid is going to be supporting as part of our pledge for and participation in the Health Collaborative. So I actually have a slide that I'd like to just show quickly. And these are actually going to be announced by Governor Cox as part of everyone's collective efforts on June 28th. At our pledge ceremony. But Medicaid has 3 health collaborative pledges. And if you see, these are in alignment with Dr. Hoffman's stated goals. The first is to increase the use of prevention activities within the Medicaid program to achieve better health outcomes for Utahns on Medicaid. So I think here you're seeing the word prevention. Healthcare integration to ensure all Medicaid members have access to quality physical and behavioral health services through an integrated approach. And we recognize that this is not a one-size-fits-all model. There are a variety of integrated approaches that exist across the state. We want to leverage our opportunities within these models, whether they're collaborative care models, coordinated activities that occur, or fully integrated systems where we can use those benefits. We know those result in better outcomes for members and patients, and we want to support those initiatives. And the third, as Dr. Hoffman mentioned, value. We want to shift Medicaid payment models to compensation based on the quality of care provided to Medicaid members rather than relying primarily on our fee-for-service or quantity of service payments. So we recognize these are lofty goals for our program. They're aligned with our core objectives, and certainly it's a many-year roadmap that we are looking at in doing this work. And it will include intense collaboration with our stakeholders and our partners in order to achieve these goals. And so as we put these goals out there, it's important for us to recognize that the Medicaid program is reliant on your input and also the voices of the members we serve in order to make this work. So anyway, those are some updates from the housekeeping side. If anyone has any questions, we can take those right now and then we can move on in the agenda. Okay, thanks for the opportunity.
Thanks, Jennifer.
You're
Good update, and it's exciting to see all the things that are moving forward at the department. So thank you. Brian, have you got an update for us on PNT?
Yeah, just a short update. In May, we met and we discussed granulocyte colony stimulating factors, and we hope to get those up on the PDL in the near future. So that would be a new PDL class.
All right, perfect. Hey, thank you. Let's go ahead now and turn it over to the University of Utah. They have a review for us of the treatments for insomnia in pediatric patients. So we'll move
right.
that over to them now.
Let me pull my slides up for you. Hopefully these.
Thanks, Val. Yeah, I wasn't sure which of you was presenting. So.
Yeah, let me, hopefully these will work. Oh. I'm having a hard time showing my my presentation here.
I do have the slide. Would you like me to
Yeah,
put it
go
on?
pull those up for me.
Yes. Give me
Thank
one
you.
second. Yeah, you're welcome.
And I'll just tell you next slide to prompt you.
Okay.
Let's see. I'll start once I see those up. Okay, thank you so much. Okay, today I will be reviewing clinical practice recommendations regarding the treatment of pediatric insomnia. You could go ahead and move forward. Pediatric insomnia is generally described as repeated difficulty with sleep initiation, duration, consolidation, or sleep quality that occurs despite age-appropriate time and opportunity for sleep and results in daytime functional impairment for the child and or their family members. Chronic insomnia is classified in the International Classification of Sleep Disorders Manual as persistent insomnia symptoms that occur at least 3 times a week for at least 3 months. In 2016, the American Academy of Sleep Medicine outlined optimal sleep durations for children that support healthy mental and physical health and development. Recurrent insufficient sleep that falls short of optimal durations is associated with attention difficulties, behavioral disturbances, poor academic performance, increased risk of accidents and injuries, metabolic disorders, and depression. Additionally, Additionally, inadequate sleep in teenagers is associated with severe psychological burden, manifesting as higher rates of self-harm, suicidal thoughts, and suicide attempts. Despite the possible need for treatment, no medications are FDA approved for pediatric insomnia. You could go ahead and move forward. Following a search for guidelines on the treatment of pediatric insomnia, we found that guidelines by medical associations primarily address pediatric insomnia in the context of autism spectrum disorder, abbreviated ASD, or attention deficit hyperactivity disorder, abbreviated ADHD. These are populations with a high burden of sleep disturbances. One key guidance statement was identified for pediatric insomnia in general, not specific to a particular co-occurring disorder. This was a guidance report published by the Florida Center Behavioral Health Improvement and Solutions Group, sponsored by Florida Medicaid. I'll refer to this position statement as the Florida guidance for simplicity. Additionally, there are several guidance statements specifically regarding the role of melatonin for the treatment of pediatric insomnia. While there are other pediatric subpopulations with a high burden of insomnia, such as those with epilepsy, cerebral palsy, Rett syndrome, cancer, multiple sclerosis, depressive disorders, etc., guidelines addressing pharmacotherapy for insomnia in other pediatric subpopulations were not found. Next slide. Guidelines for the management of ADHD address insomnia according to the following themes. Insomnia as a core symptom of ADHD with breakthrough insomnia symptoms due to the ADHD medication wearing off too early, or on the other hand, insomnia due to an arousal side effect from the medication that lasts into bedtime. In either of these situations, practitioners may try tailoring the dose and or timing of medication, switching to a formulation with a different duration of action, or incorporating a non-stimulant medication with a sedating side effect such as atomoxetine, guanfacine, or clonidine. Next slide, please. Regarding guidelines for the management of ASD, authors acknowledge minimal evidence for insomnia treatment in this disorder. Sleep disturbances may be a core symptom of ASD and or related to neurobiological alterations, genetic mutations, and disrupted sleep architecture. Guidelines advise making modifications to medications suspected to be contributing to sleep disruption when possible. Potential co-occurring conditions that manifest with insomnia can be screened for and should be treated if identified. But the root cause of insomnia in ASD can be multifactorial, as ASD core symptoms can influence sleep tendencies and behaviors and can be compounded by psychiatric or neurologic comorbidities. Comorbidities in ASD often include seizures, ADHD, and mood disorders in addition to insomnia. Ultimately, insomnia can be diagnosed and treated as its own disorder if other conditions are managed to the best of their ability, as experts acknowledge that insomnia can still persist despite the treatment of ASD, ADHD, or other disorders. Next slide. Across guidelines, the first line recommended approach is behavioral-based therapy. This includes behavioral therapy usually appropriate for young children, or cognitive behavioral therapy, which is generally appropriate for older children and adolescents. The goal is to modify behaviors and or thinking patterns that perpetuate insomnia, such as irregular bedtime schedules, poor sleep hygiene, and maladaptive habits or cognitive processes. Behavioral therapy can help young children, such as toddlers who display bedtime resistance or demands for certain conditions in order to fall asleep. The American Academy of Neurology's 2020 guideline states that behavioral strategies can be started either alone or in combination with an insomnia medication, depending on individual circumstances. Experts describe that patients with ADHD or ASD tend to have more severe or chronic sleep problems that may not respond to behavioral interventions alone. The AAN also described that autistic symptoms, including sensory integration deficits, poor communication skills, intellectual disability, and limited responsiveness to social cues, can interfere with sleep training. The Autism Treatment Network described that behavioral treatment is first line, but if this approach does not seem feasible or the intensity of symptoms has reached a crisis point, the use of pharmacologic treatment is considered. Next slide. With respect to pharmacologic options, melatonin is widely recommended across guidelines and expert consensus statements as the preferred first-line pharmacotherapy for pediatric insomnia. It is typically recommended after behavioral therapy has been tried or considered. In 2021, the Canadian Pediatric Society considered melatonin to be safe and effective for sleep disorders in children and adolescents. A 2015 International Expert Consensus Statement supported the use of melatonin for children with sleep onset problems. The Florida guidance also recommended melatonin as an initial medication option for pediatric insomnia after behavioral and educational interventions have been implemented. The AAN recommends offering melatonin to children and adolescents with ASD and sleep disturbances if behavioral strategies have not been helpful. The American Academy of Pediatrics recommends considering melatonin for sleep onset problems in ASD. And similarly, international guidelines for the management of ASD include melatonin as an option for pediatric insomnia. Next slide. Regarding ADHD-related insomnia, a 2013 European guideline recommended that melatonin can be used to help manage possible stimulant-induced insomnia or for sleep problems that are a core symptom of ADHD. Authors also explain that melatonin may be considered in scenarios if patients and prescribers do not wish to change the ADHD medication class or agent when it has been effective for other ADHD symptoms. Melatonin can also improve sleep in children with ADHD who are not on stimulant medication. The impression of melatonin safety profile when used at prescribed dosages is that side effects appear mild and self-limited, and it is not known to be associated with serious adverse effects. The Florida Guidance Report described that long-term studies out to 4 years do not show major adverse events in a variety of pediatric populations, but the impact of potential interactions with CYP inducers or inhibitors should be considered, since melatonin is primarily metabolized by CYP1A2 and 2C19. There are also quality concerns regarding OTC dietary supplements, as we do not have a pharmaceutical grade FDA-approved melatonin product in the US. Next slide, please. The Florida guidance includes diphenhydramine as an option for pediatric insomnia. However, in their separate statement for the management of ASD, diphenhydramine is not included as an option for this condition. A 2017 Spanish consensus statement was the only other guidance that included first-generation antihistamines as an option for pediatric insomnia. The alpha-2 receptor agonist clonidine and guanfacine are known to be associated with somnolence or sedation as a side effect. They are mentioned among guidelines as substitutive or adjunctive therapy to help manage insomnia related to ADHD, either insomnia as a core symptom of ADHD or as a side effect from stimulant medication. For insomnia treatment in the general pediatric population or in those with ASD, the Florida guidance includes clonidine as an option, but secondary to behavioral intervention and melatonin. Unlike the Florida guidance, medical association guidelines for the management of ASD note limited evidence for clonidine and do not go as far as to recommend for or against the use of clonidine in ASD. Next slide. For other insomnia agents, such as Z drugs like zolpidem, or orexin antagonists, such as suvorexant, there were no formal recommendations among guidelines supporting their use, since there are few or no RCTs and limited clinical experience. The Florida guidance recommended against the routine use of these drug classes in pediatric patients. It was also recommended to seek a specialist consultation if failing recommended options such as behavioral therapy, melatonin, diphenhydramine, or clonidine. Next slide. For utilization data, we queried pediatric fee-for-service pharmacy claims over a 1-year period from April last year through March of this year for non-benzodiazepine prescription hypnotics. There were 5 pediatric patients we found filling agents in this drug class. The pediatric range was 12 to 17 years old, with the majority of patients being 17 years of age. From these patients, there were 12 prescription claims total, which consisted of either azopiclone, Ramelteon, suvorexant, or zolpidem. Patients often had multiple complex comorbidities. Pulled diagnosis codes from patient records included conditions such as epilepsy, intellectual or developmental disorder, sleep disorder, insomnia, ADHD, conduct disorder, Rett syndrome, schizophrenia, bipolar disorder, suicidality, cerebral palsy, and anxiety. And the prescribing of these agents for insomnia was mostly by pediatricians and or pediatric neurology and psychiatry specialists. Next slide. So although behavioral and educational interventions aiming to correct potentially modifiable perpetuating factors of insomnia are usually the first line approach for children, there may be some patients for whom such approaches do not fully resolve ongoing insomnia. Thus, there is a need for pharmacologic interventions to help relieve the burdens and detrimental effects of insomnia. Many guidelines recommend melatonin as an option for the management of pediatric insomnia, especially for insomnia related to ADHD and ASD. Guidelines generally appear to support short-term use of pharmacotherapy when symptoms result in significant daytime impairments in function for the child and or their caregiver, and if behavioral interventions are insufficient or unable to be implemented. The Florida group prefers that behavioral or educational strategies be continued with pharmacotherapy. Beyond melatonin, diphenhydramine, and clonidine, there are not firm recommendations provided for sedative prescription medications among guidelines due to insufficient evidence in the pediatric population. If patients fail behavior therapy, melatonin, or the other limited options that can be used in the primary care setting, then a specialist consultation should be considered to determine the next approach. Since there are no FDA-approved medications for pediatric insomnia, off-label prescribing of agents may be considered, perhaps through a prior authorization on a case-by-case basis by or in consultation with a specialist. A potential caveat of this is the scenario in which a patient or provider does not have access to a specialist. And it should also be considered that the persistence of insomnia and perhaps the need for ongoing treatment may depend on whether contributing or related conditions are temporary or chronic, as underlying neurobiological alterations of chronic diseases may drive insomnia and may not be promptly curable. So that's all I have for you. Thank you so much, Noon, for sharing those slides for me.
Welcome.
Thank you. Questions, comments, Kumar?
Yeah, I just have one question. I did not hear too much about what the patient or the parents can do for them in terms of exercise and food supplements, right? And all the things that they can take care of themselves to help out the medication part, or, because it's more on medication, see?
Yeah, so behavioral therapy and practicing good sleep hygiene, like you suggest, that's all definitely the first line approach for children. And in the report, I have a section about that and a link to a toolkit that providers can use. So yeah, all the guidelines definitely support that.
Because what I'm saying is holistic approach is probably more useful than just focus on the medication, because I mean, these days, right, it's easy to keep on adding medication, and generally they're not subtracted later on.
Yeah.
Done. Thank you.
Just to follow on with that, I think most of these guidelines are pointing to that clinical scenario where all of the behavioral modifications are insufficient, and the first line, review the medications. Some of these subpopulations are on stimulant medications that are essential to regulate the behavioral problems that these patients have. And they're very difficult because those side effect profiles, I'm not generally treating pediatric patients at this point, although I have, and others in the group who are more actively involved with this. I think you can speak more to it, but the timing adjustment, all of the things that you do to regulate those medications, we still sometimes wind up with a very difficult management issue. And I think, Kumar, what we're talking about is a subset of patients who may require pharmacologic management of the sleep disorder. And so I think that's a territory that these guidelines, again, in the absence of clinical research, I think we need to develop some framework. So I'm interested to hear from our experts. But the only other comment I would make was one that I brought up at our last meeting, that my biggest difficulty with this whole area is the conundrum of not having regulated products for melatonin. And so that's our first line agent, whether it's pediatric or adult. And we need to, I think, do our best with how to manage that melatonin issue. But then the other question becomes what to do beyond that with other medications that we might have available for pediatric use, but we don't have data about safety and efficacy that we would normally want to rely on. Thank you.
Thank you. And I just wanted to, kind of highlight what I see as a major discrepancy between the guidelines and what often is seen in clinical practice. So, for example, trazodone is not in any of the guidelines, and it's actually recommended to not be used by the American Academy of Sleep Medicine for adults. And yet I see it all the time as a go-to from a primary care standpoint if melatonin is not working. And even a number of psychiatric specialists, that's kind of their go-to sleep medicine. And so, just I think keeping in mind in terms of when we're thinking about policy and formularies and things along those lines, it's really interesting in terms of the discrepancies, and there's potentially a lot of need for that education going forward, because I see that all the time with my colleagues and when I'm consulting.
One more small comment. If we can come up with a flow chart or something of that sort, that might help the framework development. That's it.
Thank you. So regarding of the covered medication that Valerie was mentioned earlier, that is Medicaid currently covered diphenhydramine, clonidine, and guanfacine with any restriction on those medication. We are not yet covering melatonin. We are in the process of considering that. So we would like the guidance from the board whether or not it would be clinically appropriate and how to frame that policy around covered melatonin. And we will have the second review on this melatonin topic at next month when we are looking at melatonin use in adult as well.
And that was actually something that I was going to mention, is that nationally, I know that that's something that comes up in my clinical work groups with individuals who do oversight with foster care populations, and variation from state to state in terms of whether melatonin is on the formulary. And, there is this conundrum because we don't necessarily have regulated products, and there have been studies and data showing the wide variation in terms of what is actually contained in a product versus what's on the label, and issues along that line. And there's also the potential for a little bit more oversight and regulation if it is on the formulary versus people just grabbing whatever over the counter. So that's kind of a thought that I had in terms of, there's potential to identify certain products as prefer, potentially that we could think about.
That is an interesting point, Dr. Gagaro, that we might be able to shape what NDC belong to what manufacturer that we're willing to cover. Thank you.
I believe
Hey.
last month in our discussion of non-24 that we had talked about at least potentially considering melatonin that was USP certified, NDCs for consideration for coverage for over-the-counter products.
We did say that.
You might
We
also
did, and it sounds like we're coming there. You guys are coming back next month, right?
Yes.
For us to have a larger conversation on melatonin. So I think that's definitely on the table for us. I think the question in my mind is, and I like Kumar's idea of some kind of pathway for physicians, but it doesn't sound like on the whole, there's a lot of data available nationally, even in this space. And so, and I can tell you based on our data, there's a whole lot of trazodone used, and it doesn't have a lot of other uses. So anyway, and any other comments, suggestions? And then Noon, or is the department looking for us to make any recommendations, decisions in this space today?
Not yet today, but we would like a more guidance to how to clearly shape the policy after the next meeting when we have like an overall melatonin in children and adults.
Okay.
I'll just add, you might also want to consider consumer labs, their verified products, because they have a similar process as USP. And actually, I had called both companies and inquired about what they actually test, because it's very non-transparent to me. Actually, Consumer Labs does a little bit better job at putting on their website what impurities they test. And after talking with the representative, I found that they mainly look at 3 metal impurities. And I was more concerned with serotonin, because that's what has been reported in that study where they looked at over-the-counter products in Canada, and that I see people cite, as far as impurities go. So serotonin is actually can be in some of these products, but it didn't sound like they screen for it, and I kind of doubt USP screens for it. But the representative that I spoke with, she requested that I submit the information I found, and they said they would submit it on to their scientific team, and they would consider incorporating that into their quality assessment. So I think the more they hear about what impurities we're interested in these different products, then I think they're willing to take that on. So that was at least somewhat promising to hear.
It's not only the toxicity, it's the consistency of the product, right? Some of the other analyses that have been done show that there's ranging from 0 melatonin, right? So that's also my concern. The purity studies, of course, if there's, if these manufacturers are putting other sedatives in so that somebody gets a sleep effect, and if it's serotonin, that's very concerning for our patients who are on other serotonergic drugs. So, and that would be, very dangerous in some cases. But we also have the concern with the, with the inconsistency of the actual contents of the product. And while there might be just filler that's harmless, what we're trying to do is step up through a protocol that says a patient might have a trial of melatonin. I believe this is what we discussed last time. Patient steps up through a trial of melatonin and they fail melatonin, but we honestly don't know if they've actually had a consistent therapeutic trial. And that's what I'm calling the conundrum. Aside from the purity and the possible toxicities of, goodness gracious, you mentioned metals and other things that are consumer beware on those things with supplements, but the dosing consistency, if we're designing therapeutic trials in a stepwise fashion through a protocol, then I have great concern that the patients aren't actually getting consistent trials, and in the pediatric population that would also be concerning. I don't know if I haven't looked to see if there are liquid melatonin formulations, because I haven't tried to give melatonin to very young patients. Dr. Gargar, are you saying no or yes? Yes.
Yes, there are absolutely.
yeah.
There's liquid, there's gummies, there's chewables, there's you name it as a formula.
So there we also have probably consistency issues with all of these different dosage formulations that would be applicable to the pediatric population. And so that's really the conundrum that I'm most concerned with. How do we step patients through the therapeutic trial and failure when we can't actually confirm they're getting consistent dosing?
Kumar?
One small comment, and that is about standardization of therapeutic trials. If there is some standardization and then the research data becomes available, then that'll be a lot more authentic. That's it.
Yes, absolutely. And I think we would all love to see more standardized trials and information on herbal products. So definitely need some support from federal regulation to allow us to get that data. Why don't we move on? And I think you guys have got PA criteria for ophthalmic injections.
Correct. Yes. Thanks, Eric. So we are proposing a change into the intravitreal implant and ophthalmic injection prior authorization. The criteria for approval that's requiring all of these criteria under here need to be met is implant or injection is prescribed by and administered by an ophthalmologist. The patient is at least 18 years of age for prescribing information, exception to registered, which is 12 years of age and older. For Iluvien, which is fluorocinoclone acetonide, additional criteria is patient have to have the diagnosis of diabetic macular edema and previously treated with ophthalmic corticosteroid without a clinical significant rise in intraocular pressure. The patient has previously undergone at least one prior macular laser treatment. The patient doesn't have any of the following, which is contraindication is glaucoma with a cup to this ratio of greater than 0.8, or active ocular or periocular infection. For Ozurdex, which is dexamethasone, diagnosis of DME or macular edema following branch retinal vein occlusion or central retinal vein occlusion, non-infectious uveitis affecting the posterior segment of the eyes, and also doesn't have any of the contraindication listed. Retisor, which is also fluorocinoclone acetonide, diagnosis of chronic 1 year or greater non-infectious uveitis affecting the posterior segment of the eyes, and also doesn't have the contraindication listed by the prescribing information. Additional is patient have to have a trial and failure a course of Humira for at least 6 weeks within a last year of requesting. For titration. Also very close to the prescribing information is indication for the treatment of sympathetic ophthalmia or temporal arteritis, uveitis, and ocular inflammation condition unresponsive to topical corticosteroid or visualization during vitrectomy. Patient doesn't have a systemic fungal infection. For Sapir, which is indication for the treatment of MEA associated with uveitis, and patient doesn't have the ocular or periocular infections. The last one is UTIS. Patient have to have a diagnosis of chronic non-infectious uveitis affecting the posterior segment of the eyes, and also doesn't have contraindication, and also have a giant failure course of Humira. We authorize 1 implant per approval. Injection number to be determined on individual case review. For REART, we permit the injection for the opposite eye if the treatment for the first eye is successful. Regarding the utilization, right now the only medication that we have any patient under is the Ozurdex. We have less than 5 patients is currently using Ozurdex. That's all for the PA proposal.
All right. Any questions or comments about this PA criteria?
When I just read the title of the PA, I thought it was a little worded a little strangely, because I immediately thought of, ophthalmic injections as being including other classes of medication. So I sort of thought maybe, changing the title to ophthalmic steroid intravitreal implants and injections might be a more clear title for this PA, so that people know they're talking only about corticosteroids as opposed to biologic agents that are being injected into the eye, which I'm sure have separate PA criteria.
No, I agree with that. My initial thought was of the anti-VEGF products, so absolutely. Other comments on the criteria?
Comment. I was just wondering if the language could be streamlined a little bit. There's some phrasing that's similar but not exactly the same, like active infection versus infection. And I also wonder if maybe this could be condensed to a table, since so many of these criteria are similar.
All right. Other comments? Noon, would it be possible for you guys to put this in a table and email it back out to us, and we can have just a quick conversation about it at the beginning of next meeting and approve it?
Absolutely, yeah. Thank you for that comment. And also regarding the name of the PA, we can wordsmith that. Would you repeat the recommendation, Dr. Sikri?
What I had thought of was ophthalmic steroid, intravitreal implants, and injections. To basically separate this from biologics, anti-VEGF, other products that are injected into the eye, because all of these are corticosteroid class medications.
Thank you. We can make those recommended change, including the PA title, and then re-put the criteria into the table for easier flow and bring it back to the board at the next meeting for a motion.
Great.
Do you want to say corticosteroid, just to be technically accurate there? if that is correct, and any of
Yes, I just was trying to,
ophthalmologists in our group.
trying to keep it on one line. They may
Yeah.
need to
No, I don't
decrease
know.
the font a little bit. That was my only, when I tried to do that, it kind of ended up on 2 lines. They may need to decrease the font, but that was the only reason why I said sterile.
So good. Any other recommendations regarding the criteria specifically?
It does not sound like it.
Perfect. Thank you.
All right. Anything else for us to cover today? Looks like we'll be talking about insomnia treatments in adults next month, where we will continue this melatonin conversation.
Yes. And we will also have more information about melatonin coverage from other Medicaid program to give the board an idea of how across the country other Medicaid program cover melatonin, and also like a more refined proposed policy around the coverage for melatonin with youth on Medicaid as well.
Okay, great. With nothing else on the agenda, do we have a motion to adjourn? Kumar has a motion to adjourn. A second?
Second.
Second. We are out of here, guys. Thank you. Have a happy day. It's a nice sunny day. Enjoy summer. We'll talk to you guys all later. Bye-bye.
Thank
Have a
you.
great day, everyone.
Okay.
Thank you.
Great day.